Welcome back to Four Eyes, the podcast series that gives you a clear view into the optometry world across Canada and the US. Today, we're talking about that pesky double vision and what you can do to figure out where it's coming from. Here are your hosts. I'm Dr. Amrit Bilku.
I'm Dr. Deepan Kar.
Hi, I'm Dr. Ravinder Randhawa.
And I'm Dr. Alex Kuhn.
How was your guys' week?
Well, we're back at work, me and Deepan.
Yeah, we're back at work. Barely, though. But yeah, we're only seeing like maybe a patient every hour, maybe not even that. Wearing all that PPE.
Yeah, Rav, you have to wear like actual headgear.
So they gave us a face shield, but I can't see anything out of it when I'm doing behind the slit lamp.
So my employer was like, oh yeah, we'll do face shields. And I was like, okay, so how am I supposed to use the slit lamp or do anything that's important for my job? Yeah.
They got us goggles instead now. So
Goggles?
I wear the goggles.
Do they leave marks around your face too?
Yeah. But I only wear it when I like do the slit lamp. Like I don't wear it before.
Mm-hmm. I have a lot of trouble wearing my face mask and the patient wearing a face mask and me doing a 90.
Yes.
So this like 2-minute part of the exam ends up taking me like 7 to 8 minutes. So I guess it's good we see a patient every hour, but I was like, oh, okay. These are some pretty big adjustments that I didn't think about right away. So yeah, that wasn't too fun, but you know, at least we're grateful for being back. So yay.
Okay, so let's get into double vision today. Double vision is a common complaint and symptom that many of our patients experience, and sometimes the cause can simply be an uncorrected refractive error, whereas other times it can be a lot more serious. So in today's episode, we wanted to discuss how to approach the management of simple to more complicated double vision patients using detailed case history questions and additional tests that you can try in your practice setting. So first of all, the assessment of the patient's perception of diplopia must exclude other symptoms that can be misunderstood by the patient, such as image distortion, a visual field defect, or after images such as ghosting. And then determine whether it's monocular diplopia or binocular.
This happens a lot where people will come in to clinic and be like, I have double vision. And it's like, no, it's blurry vision. Not double vision.
No, that happens. I think that happens weekly for me.
Yeah.
That I have to really...
I always start sweating when someone's like, I have double vision. I'm like, no, I don't want to take out all this prison and like all this stuff.
And this is exactly why we're doing this episode today. So hopefully you guys do not sweat when your patient comes in saying I have double vision. And I feel like that's a really good point, Deepan. Like the first thing that should come to your mind, you should automatically be thinking, okay, first of all, is it actually double vision?
That's like the first question that comes to my mind. But then when it is actually double vision, then I start sweating and I'm like, no.
Yeah. What kind of questions do you ask your patient to make sure that it's double vision versus like distortion or a visual field?
So I'll actually hold up my hands and be like, are you seeing two separate images of this? Or like, I'll be like, okay, what
like,
are...
do you see two of my hands here when I show you one hand? Okay.
And then they'll, 80% of the time they're actually like, no, it's just blurry, or this is distorted or something else. So it's, from my experience, 80% of the time it's not actually double vision. They just say it's double vision.
Yeah.
I do that too. And then I'm also like, does it happen with your glasses on or without your glasses on is a big thing. Because there's a lot of people, it tends to be elderly people, I've noticed that. They're like, my vision has changed. It's just blurry. I'm like, well, when you wear your glasses, does it make it clear? Yes.
That's one of my biggest pet peeves. Like, I don't understand that. I don't, like, or they'll be like, my vision is getting worse, much worse. And it's like, with your glasses? No. my glasses is fine. I'm like, okay, let's keep on going. Let's
keep moving. Basically, you're done for today.
Yeah.
So the first thing you always want to ask your patient is, when you cover one eye, does it go away? If it goes away when they cover an eye, obviously it's binocular, and then you can start to do your tests that we'll mention to figure it out. If they cover an eye and it's still there, you know it's monocular, so something's going on.
So monocular diplopia is often caused by uncorrected refractive error, so especially with patients that have high astigmatism. And another major cause is cataracts.
I feel like those are the common ones. Really high astigmatism because the images start stretching out from one another, and then cataracts too.
Also dryness.
Yes, and dryness, dry eye.
So with cataracts, you can get like the decreased visual acuity and the haze that can appear as diplopia. And the type of cataract is mainly the cortical type of cataract that causes the haze a little bit more. So you can have macular disorders that can cause metamorphopsia, which is evaluated through the Amsler grid. Other causes, as Stephen and Alex mentioned, dry eyes is a big one. Also, contact lens that don't fit well, any irregular corneal surfaces, keratoconus, any abnormalities of the iris, so iridodialysis, polychoria, any large iridotomies. Vitreous opacities can also cause monocular diplopia, and IOL subluxation.
So I found a really good, thorough article online about like a step-by-step approach to evaluating monocular diplopia. And you kind of pretty much start from like the front of the eye, and then you rule out all the causes as you go towards the back of the eye. So if someone's complaining of monocular diplopia, the best thing you can do first is just put the pinhole right in front of them and ask them, does it go away when you look through this pinhole? If it doesn't go away, you know that there could be some sort of maculopathy, so something in the back of the eye that's causing it to occur. If it does go away, now you know it could be one of the following structures, and very similar to what Rav already kind of mentioned, so we'll just briefly go through it from like front to back. So if it does resolve with pinhole, check their refractive error for the astigmatism. Check their eyelids for any eyelid growth or tumors that could be mechanically compressing the cornea. Check their tear film and for dry eye disease. Check their cornea for any corneal opacities or scars that could be affecting their visual access, and also if they've had like post-refractive surgery. Then you want to check their lens to see if there's any subluxation or any cataracts developing. Checking their iris for the abnormalities that Rav mentioned. For any sort of iridotomy, you can also check to see if the eyelid completely covers the iridotomy or if it covers it partially, because then you'll know if that's the true cause. And then check for any vitreous foreign bodies. If none of those things are showing up, once again, check the macula, take an OCT scan of the macula and see if there's any sort of distortion in the retina that's causing it. Now, I found this really interesting that was mentioned in the article, if the monocular diplopia is in both eyes.
This is when I would be very scared if that happened.
I think I would give up my license and be like, I can't practice anymore. I don't know what's going on.
Yeah.
But yeah, if the monocular diplopia is in both eyes, this is quite rare, but it can be associated with a psychological disorder or cerebral polyopia. Cerebral polyopia is basically the perception of multiple images due to some pathology in the occipital cortex or somewhere along the visual pathway. So if your patient covers an eye and the double vision goes away, then this could be binocular diplopia. And so case history questions are crucial because it will help guide your diagnosis of what's causing the diplopia before you even start your testing. So it'll really help you narrow down, like, what test do I need to do? Where do I need to look to figure this out?
One of the main questions you want to ask is, how long have you had the double vision for? So this is important for determining if the double vision is long-standing versus an acute occurrence. So an acute onset is more suggestive of a vascular event, but is not very specific. And the gradual progression of diplopia that has changed patterns over time is more indicative of a compressive lesion.
Yeah, usually I feel like acute could also be trauma, but I feel like you can, if your patient says I had a car accident or something, I feel like you can easily put the pieces together.
Yeah. And the patient usually comes in pretty distraught too. They'll be like, what just happened to me? You're like, yeah, oh, okay.
Another important questions to ask is, are the two images, are they separated horizontally, vertically, or diagonally? Anytime a patient says it's separated horizontally, so that kind of suggests any medial rectus or lateral rectus dysfunction, such as a sixth nerve palsy. Also INO, so the internuclear ophthalmoplegia. Any horizontal diplopia that tends to appear after doing long near work, that tends to point towards more CI. Any vertical diplopia can suggest the fourth nerve palsy or skew deviation. So kind of a little bit of review of the skew deviation. That's when one eye is intorsion and the other one is extorsion, right?
Yeah, there are actually a few interesting factors that make skew deviation different from a fourth nerve palsy. So, as skew deviation results from vestibular dysfunction, typically when you perform the cover test in a supine position, the vertical posture will actually decrease by 50% or more compared to what you measured in primary gaze when sitting upright. And if it was a regular fourth nerve palsy, the vertical posture should stay the same or be quite similar in upright and supine. Also, in skew deviation, the hyper eye tends to have incyclotorsion and the hypo eye will be excyclotorted. So that's also a big differentiating factor from a fourth nerve palsy where the hyper eye is always excyclotorted. And obviously, if it's a monocular fourth nerve palsy, the fellow eye wouldn't be affected at all. So yeah.
You can also have vertical diplopia and with anyone that has any thyroid eye disease. So remember, with thyroid eye disease, the inferior rectus muscle is the one that's most commonly affected first. Also, with anyone with orbital floor fracture or any supranuclear or infranuclear brain lesions.
I know we always talk about, I just want to make sure it's clear with you guys too. So we always talk about thyroid disease and how it can create that problem, but it's not thyroid disease, it's hyperthyroid disease, because hypo doesn't create a problem with.
It can, but less common. Graves' disease is more common to cause thyroid eye disease compared to Hashimoto's.
Okay. So I always wonder, because I feel like most of the time when they say thyroid disease, most people have hypo, but yet most of the symptoms are hyper that they talk about.
That's good to point out.
Mm-hmm.
Another great question to ask, is it worse at distance or near? Distance indicates that it could be a lateral rectus dysfunction or divergence issue, whereas a near problem would be medial rectus dysfunction or convergence issue.
The next question you can ask your patient is, in which direction does the double vision get worse? So if they are getting diplopia in up gaze, and especially if it's vertical diplopia, then it could likely be a third nerve palsy or even just an inferior oblique overaction. Vertical diplopia in down gaze is going to be more likely a fourth nerve palsy or skew deviation. And if the patient really doesn't know and reports that the diplopia kind of gets worse here and there in different directions and kind of everywhere and all over the place, that's when you're probably going to start considering some more systemic diseases or orbital inflammation like Graves' disease, myasthenia gravis, or multiple sclerosis, especially if the diplopia varies during the day and gets worse throughout the end of the day. Then, once again, more suggestive of systemic conditions.
And then you want to ask them if they have a history of congenital strabismus or surgery or a head turn. So usually comitant deviations do not induce diplopia due to cortical suppression. So This usually happens with patients that have congenital strabismus. And then just as a review, comitant deviations will be equal in all directions when you do your cover test. The head turn will tell you if it's been long-standing. And then adult onset of diplopia could be decompensation from childhood strabismus.
So you kind of also want to ask your patients if they're having any associated pain, headache, or any other neurological symptoms. So sometimes with the nerve palsies due to vascular conditions, you can also get headaches. So vascular conditions, we're talking about hypertension, diabetes, or GCA. I know that if a patient has high blood pressure or diabetes and they're complaining of headaches and they have the diplopia, you're supposed to send them out for an MRI. But if they don't have the associated headaches, then you can just kind of monitor them. Mm-hmm. It tends to resolve by 3 to 6 months.
Yes.
Yeah.
What I want to talk about is I had a patient. So this is during rotation. So he had a cranial nerve 6 palsy. So we saw him. We told him to wear an eye patch. He had high blood pressure and he had and diabetes. And then he comes back and then he's complaining of a headache. And we're like all worried. We're like, oh shoot, like this is something more serious. But then we realized that he was having these headaches that were more towards the end of the day because he wasn't wearing the patch and he was just closing his eye all day long. So that's a very important thing you want to ask your patients too. Are they wearing the eye patch or are they just like shutting their eye all day long?
Yeah.
Because that will cause a headache.
Or if they just don't wear the eye patch and they're seeing double all day, I get a headache if we start doing...
That would give you a headache, probably,
that would
I'm
give
sure.
me a headache, yeah.
I feel like those kind of cases where, you know, the patient doesn't tell you the whole story and then you kind of jump to all these conclusions, that happens
every
a
day.
lot. I feel like, because you're just, especially if you don't probe further every single time and you're like, well, like that's so simple. That's something I wouldn't even think about to ask the patient to be like, have you been wearing your eye patch? Because that's like a therapy we discussed at the last appointment where you'd be like, okay, I'm assuming you're doing that.
Yeah, side note, that's a lesson that I've really learned a couple of times throughout optometry school.
Yeah.
Is ask really thorough questions at your follow-up visits after you've given a treatment option, because half the time the patient says, well, it still doesn't feel better, and you're just kind of like, okay, let's try this instead. But I forget to ask, well, have you tried XYZ, and ask it very thoroughly, like how many times have you done it, when's the last time, all that stuff.
I tend to have that happen with like warm compresses, people with dryness,
Mm-hmm.
and they're saying, oh, I'm doing everything and it's not working. I ask them open-ended question. I'm like, so how do you do warm compresses?
Yeah.
And how many times do you do it? Like, I do it.
How do you wear the patch on your face?
But really though, I mean, if you let them tell you instead of you saying, do you wear the patch on this eye, you know, because they'll say, yes, I do that, rather than, you know, kind of what they're probably doing.
And that's very important for amblyopia too. You want to ask the patient, which eye, can you show me which eye you patch?
Yep.
And it's always, sometimes when they don't improve, it's always the wrong eye they're patching.
Yep. And so once you've asked all your patients these thorough questions, that should already give you an idea of what you're thinking is causing the double vision. And the following tests that we're going to talk about are pretty much suggestions of things that you can try to see if it helps you identify the cause. So first thing you always want to do is check their glasses and make sure they're aligned, especially if they have progressives or really high astigmatism.
This is true. There's so many elderly patients will be like, I have double vision. And then you literally just lift their glasses like a little bit and they'll be like, oh, it's gone. And you're like, okay, great.
I think it's actually not even for progressives. I think line bifocals. Yeah. Because if they're looking right through that line, it's over. It's game over for them. So yeah, definitely adjust their glasses first and see if that really helps the problem. Especially if they say they have double vision with their glasses on. That could be a good indicator. I think the first thing that everyone is probably thinking about when they hear about double vision is cover test. Let me check if you have a strabismus. Let me check if you have something weird going on. So you pull out your prism bar and your occluder. You're going to normally in every primary care exam, right, check their primary gaze cover test at distance and near. But you can also do it you can also do it subjectively with a Maddox rod to let the patient tell you what they see in their eye alignment, especially if they have like a small vertical that you're not noticing in your cover test. So Maddox rod is a really good idea. And then a lot of people have heard of doing cover tests in 9 fields of gaze. That is definitely a very long test to do and very difficult to do. I would recommend, at least at the bare minimum, if your patient complains of double vision in any gaze that is not primary gaze, I would at least check cover test in that area, right?
Yeah,
like
I think that's what we were taught in our rotations, because I know in school everyone was taught to do the cover test in the 9 fields of gaze.
Yeah, it's a lot.
That's like that. I remember when I practiced that took me almost an hour. And I was like, oh, so my appointments will be like 3 hours long for each patient that comes in like this. But that's exactly what my preceptor told me for my rotation. They're like, just check it in primary gaze, but also in the gaze that they're struggling with, and then just move on from there, because you're not going to have that time to check all 9, especially if you're in private practice. So
yeah, you want to do this test because that will help you to figure out if this is a comitant or non-comitant deviation. Basically, is it acute within the last 3 months, or is it long-standing? And if you want to do a cover test in different fields of gaze, the difference between 2 gazes, if it's more than about like 10 prism diopters, it's likely non-comitant and acute. So like if you're comparing primary gaze to left gaze and there's a difference of 10 prism diopters, it's probably acute. What else you could do that's a little bit faster than 9 fields of gaze is checking primary and secondary fixation. In my opinion, the easiest way to do this would be to perform your cover test with the Maddox rod twice. So the first time you can put the red lens over the right eye. So we're doing left eye fixation, and you can measure their cover test in primary gaze. And then you can repeat the test with the red lens over the left eye. So now we're doing red eye fixation. And again, if you do cover test twice and there is a difference of, again, 10 prism diopters, it's likely acute and non-comitant, and there's something going on.
Okay. Well, with the Maddox rod, you can only do near, so I guess you have to do prism bar for distance.
You can actually do Maddox rod for distance. You just wouldn't use that modified Thornton. If they're looking at a bright light far away, okay, and they have the red line over one eye, you have to use your prism bar now to say, tell me when the red line goes over the white light. And so then you're physically measuring how much it takes.
Okay.
The modified Thornton card is really nice at near because if you do it at 40 centimeters, it's already measured out how many prism diopters on the card.
I completely forgot this.
Yeah.
This is really good review.
Yeah, so once you've identified any sort of strabismus, then, based on your case history, you're more likely to figure out what it is, like if it's some sort of a nerve palsy. But let's say you still can't figure it out, and the patient's still complaining that they have double vision in a certain gaze. So versions testing, not vergences, but versions, is a really good test that you can perform quickly in all 9 fields of gaze to isolate the affected muscle or muscles and help you consider your differentials. So versions is done binocularly, often without their glasses, and you just use a transilluminator and you watch their corneal reflexes while you move the transilluminator around. It is not like EOMs, but it's similar. So you have them follow a pen light, and you're basically making a box instead of an H around their eyes. And then you basically move with the transilluminator so that you can just check their corneal reflexes to make sure they're still aligned the whole way through. Versions will show you if any muscle is overacting or underacting, right? And then ductions comes into play after versions. Ductions is done monocularly, and you guys probably heard of this as forced duction tests, which is often done under anesthesia because they have to take these forceps, grab the conj, and literally physically shove the eye to see if it moves. And realistically, we're not going to do that on our patients.
I don't think anyone does that in clinic.
There is more of an alternative ductions test that you can do that still gives you a lot of information, but of course it's not that gold standard ductions test, right? So let's say we have to give an example for you guys to really think about this test. Let's say, for example, a patient is looking into left gaze and their right medial rectus is, let's say, underactive. That's on versions. OU, both eyes are open. What you can do in that problematic gaze is have them look again in left gaze. Cover the eye that's not an issue. Like basically, you don't care about the eye that's not giving you a problem, right? So you're actually going to cover the left eye while she's still in left gaze. Check that right eye to see if it moves any closer to the pen light. Even if it's any amount of movement, it would be a neurological restriction, something affecting cranial nerve 3. Adductions test is positive when there's no movement. So let's say you cover that left eye, she's looking in left gaze, and the right eye still never moves. It's like frozen. That's a positive ductions test where something mechanically is restricting that muscle from moving, so that's physically not able to move. And for anyone who wants a physical example of aversions versus ductions test, on our Instagram post, we did post a picture of a patient that had a bilateral fourth nerve palsy, and I posted a picture of me doing versions versus ductions, and the explanation is in there too. So go check it out if you want a little bit more of a visual of what I just explained.
That's a lot more traumatizing that's a lot less traumatizing than the forced deduction test.
Yeah. I feel like if I were to do the forced duction, that would probably cause like a subconch heme.
That's what I was thinking.
I know. That's what I was always afraid of.
Very basic things that everyone does again. Check their vergence ranges and check their NPC to make sure you don't have any convergence or divergence, insufficiency, or excess. Your vertical vergence ranges are important because if they have a vertical strabismus or vertical phoria, expanded vertical ranges indicates a long-standing vertical strabismus. Park's 3-step. Have any of you done Park's 3-step?
During rotations, just once, but
at the VA, one person who was at the VA with us had to do Parks 3, and she told the attendant she remembered how to do it, and she had to Google it and ask us how to do it because she completely forgot. And I was like, oh no.
Park's 3-step is used mostly for only diagnosing an SO palsy or fourth nerve palsy. If you circle any other muscle on that test, it's basically inconclusive. So that doesn't mean that if you circled something like an IR muscle, does not mean it's an IR palsy. You need to do the other tests to figure it out.
I think that's why I don't like Park 3-step, because I'm like, is it going to be worth it to do this? Will this help me figure it out?
It's pretty quick though, really.
Well, the other thing is, I feel like a lot of people forget how to do the test and they just can't remember. So iDoc.com has a really, really good platform where you could just ask all 3 questions, put in right or left. You don't even have to think about it, and it just tells you which muscle it is, and you're like, all right, good to go. So there's a lot of apps like that on your phone.
Those are pretty much the main tests you can do for double vision. And you don't have to do every single one. Your case history will basically tell you what test to do to figure it out.
I had my techs, they come up to me this last week and they asked me, so how do you figure out, or how do you know which muscle goes with which nerve? And I was like, oh, in school they taught us this really simple way to know it. SO4, LR6, the rest is 3. And they're like, that's not simple. They're like, that's not a good jingle. I was like, okay, well, it's good. We could remember.
So the next thing we want to talk about is what we should be ruling out when someone comes in with double vision. So post-operative diplopia, also known as intractable diplopia. So this basically means the diplopia cannot achieve fusion and one eye must be occluded for relief. So some patients may develop double vision after surgical procedures such as refractive, cataract, glaucoma, strabismus, or retinal detachment surgeries.
I was just going to say the use of scleral buckles for retinal detachment may cause diplopia due to the injury of the extraocular muscles. And also, diplopia can be present following strabismus surgery in patients who are overcorrected.
Yeah.
Younger patients can suppress the deviation, unlike adults, or if the suppression was before surgery, they might not be able to shift it.
Intractable diplopia basically occurs because something happened externally, right? So mainly surgery, that is now causing both eyes to see clearly, or for both eyes to see something that they cannot fuse together anymore. So especially for patients that are now going to go through a refractive surgery or cataract surgery, something that is basically permanent and likely not reversible, you want to check for their eye dominancy first. See if they actually have a preferred seeing eye, because that tells you that you might not want to correct the other eye, their weaker eye, because if you do and you make them see clearly out of it, they're going to stop suppressing, they're going to see double vision, and they're probably not going to like it, and it's irreversible. And I don't think this is going to come up every day in your chair, but if you have a patient whose binocular vision status is already a little iffy, I think those are the people that you might want to caution a little bit more about getting cataract surgery or refractive surgery. And you might want to refer them out for BV testing to see, is this surgery that they're going to cause them more issues?
Also, I do think it's important to make sure you check the patient's dominant eye, because when I'm fitting contact lenses, especially like monocular or multifocals, I always check the dominant eye. Most patients, even up here, which we do a lot of like shooting and mainly shooting, and so people think they know what their dominant eye is, and then I test that, and it's usually opposite. Or there's a few times they're spot on, but a lot of times they don't know.
Yes.
Even though
that's a really good point too.
Unless it's like for glaucoma or retinal detachment, because you sometimes have to do those surgeries. So
yeah, you have to.
But
yeah.
Those refractive,
what's it called? Elective
surgeries like LASIK. Yeah, elective.
So another thing you want to rule out is any orbital disease. So you want to be checking out for any proptosis, any edema, any lid retraction, uveitis, injection. So again, like asking your case history about any thyroid, especially hyperthyroidism, sarcoidosis, lupus, arthritis, again, your signs of GCA.
And then what can we do for patients that have double vision?
The management of diplopia must be according to what is causing it.
Yeah, so I would always trial the prism in office, have them walk around and see, if it gets better with that. If, occlusion is still an option for some patients, depending on their situation, like if it's more of an acute onset and we expect it to go away.
For anyone that has diplopia due to a vascular condition, I feel like prism is not the best option because as time progresses, it slowly gets better. They will constantly need updated glasses, or they can get the Fresnel prism.
You also don't want to I wouldn't give prism to the patients that are like, my double vision's like everywhere and it changes every 2 seconds, because, then they end up buying glasses that won't work in like a week or something. So I would just go with patching in that kind of case. But like if they already have prism in their glasses and if they're 100% okay with everything, don't change it. Don't change it unless they're having like symptoms. Even if they, if the double vision has become worse, but they're not noticing anything, don't change it, because then you're just going to cause so many follow-ups for yourself. And
Another option too, though, what we do, my dad and I do in our clinic, is we have Fresnel Prism. And so if it is vascular related, we will start with Fresnel and then have them come back and then decrease the Fresnel as it gets better, kind of thing. And that helps a lot. We actually had a patient that had a pretty important job that he needed basically both eyes for that job because he was assisting in surgeries. So the Fresnel Prism helped that person out a lot.
That's a good point, though. Like, for those, I never thought about that. For those patients that need binocular vision, Fresnel Prism's a really good option because it's cheaper than just getting Prism in your glasses.
But even like instead of like an eye patch, even just taping, putting like frosted tape on the patient's lenses if they already wear glasses, that's another good option for the patient that looks a little bit better than an eye patch.
I just remember the sticky note.
Or the Post-it note.
What interview was that from?
That was with Dr. Lee.
The Post-it note.
Dr. Lee, amblyopia.
Dr. Lee said that? Yeah.
Yeah.
Obviously, for patients that have had some sort of long-standing double vision due to any sort of strabismus that's decompensated, Prism is a really great option for those patients. And another interesting thing about Prism, have that conversation with your patient again and again that Prism is not available in contact lenses.
Oh, yeah.
I feel like it is the hardest conversation when your patient needs Prism, but they love wearing contacts. That's like the hardest
There
one
is Prism in contact lenses, but not for why.
Not for what you need it for. Exactly.
So, and for your patients, especially for anyone that has like decompensated fovea, don't want to forget vision therapy for them as well.
Yeah. Vision therapy is probably going to be beneficial for a lot of these patients who do not have diplopia from like a vascular disease or a systemic disease where the diplopia is always changing. However, even in those types of patients, like patients who have Parkinson's disease, for example, even though their condition is progressive and it gets worse, we actually still offer vision therapy to those patients. And we have particular patients at our clinic who have Parkinson's that do VT constantly throughout the years to maintain the level of binocular vision that they have so that it doesn't progress as quickly with their disease. So it's still an option that you can give to them and see if that's something that they want to pursue. Vision therapy is always a great option for them too.
Thank you to everyone for listening to 4 Eyes. If you enjoyed this episode, please be sure to subscribe and leave us a rating to give us feedback on how we're doing. You can also check us out on Instagram at 4EyesOptom for more content. Look out for new episodes every Wednesday. So until then, stay tuned.